Dr. Jignesh sir for his remarks
Yeah.
on the video. Yeah.
So I think that was a nice disposition between me and Vivek. Essentially for the students, again, it's very important because abdominal examination or lump in abdomen is always a very critical challenge for the patient. We've gone through the main important points that you have to introduce yourself to the patient first, take them into confidence. Sometimes even a gentle first cursory talk about where does the patient stay and all that in the history, and then make them more comfortable so that they can do and cooperate with you very, very well. Once you have done that, because there are a lot of times you're going to touch the patient, you're going to do a lot of palpation, you're going to do percussion and all those things. So patients become uncomfortable, but take them into confidence. And I can tell you, if you take them into confidence, there could be certain signs, which you have missed, but an intelligent patient will always get back to you and tell you. And I still remember my days where the patients used to tell me कि sir ये इधर कुछ तो है वो आप देखो क्योंकि examiner is asking for that. So sometimes if you have taken them into confidence, it always definitely helps. And I'm sure each one of us has gone through that kind of a concept. At the end of it, not to miss is, we also do a part of examination of the spine as a part of the abdominal examination, which I should definitely insist. And that is also, a special emphasis because sometimes you may have a pot spine. So in general, examination of abdomen is what we have talked about. We will have modules where we'll be talking about, say, a lump in abdomen, where you have to go into great details. But by and large, if you sum up everything, I think it's a pure mathematics in abdominal examination. And the Pandora's box is no more a Pandora's box, because if you follow a particular pattern in your clinical examination, I'm sure you will definitely do very good in your exam case. So that's from my side. Any other, I would like to have inputs from our senior faculty members. Let's start with Dr. Kaza first. Kaza, sir.
Thank you, Dr. Jignesh. I think that was a very comprehensive and complete coverage and nice discussion too between the two of you. It was very interesting and lively. But there are certain things that I would like to sort of more in a discussive fashion. You have given classical methods of examination. And in today's times, I keep wondering about certain aspects of our examination. One is with reference to the fact that the limb should be folded. Must be so that the abdomen becomes relaxed. And the second one, I would like to know your comments. Is it that when we have limbs extended, the abdomen is always tense? The second thing is about the examination of organs like liver and spleen. We were taught, like you have shown also, that we should go up from vertically above for the liver and we should go diagonally for the spleen. And is that a too long a way for more mildly enlarged livers or probably just enlarged spleens or something? So are there any alternatives to that situation? And the third thing about the shape of the abdomen, quite often I have seen this happening in the exams also. The students' legs are being pulled on this particular thing. Maybe if we consider 3 categories instead of 2 or 1, and that is if we call it as a flat abdomen, scaphoid abdomen, distended and protuberant abdomen. If you put it into 3 categories, maybe it will be more easier to describe the abdomen because classical scaphoids are difficult to find. Most of the time in reasonably nourished patients. So that is one other point that I had. But otherwise, the discussion has been very illuminating. It is very both lively and illuminating. And I'm sure the students would have learned a lot from this.
Yes, thank you, sir. So, just quickly upon your first point, yes, what happens if you have a patient who is a muscular, a well-developed patient with a good, strong rectus abdominis, quite often it becomes difficult if you're, having a patient who is completely leg stretched. I can imagine in a protuberant abdomen where the muscle tone is weak, you can definitely go ahead and do your palpation too. Yes, sir is right that you can have those combinations. But this was a question which was, given to me in my residency days. And it took me a couple of days to go to the anatomy hall and actually find out. And then that's where, the explanation of pelvis came in. This is what happens when you relax the tensor fascia lata. Because my boss used to tell me that, okay, you have flexed the hip, but why do you want to flex the knee joint? And that boggled me because the tensor fascia lata then has a continuation with the core muscles. And that's where you do that. Second second thing is about palpation of the organomegalis. Yes, we can definitely start off, but the spleen specifically, the reasons which were told and which also are anatomical is that during the development stage or the rotation of the gut, the spleen actually is in the right iliac fossa and then it slowly starts moving towards the left upper abdomen. Second thing is for the students, there is an attachment to the diaphragm and to the colon. So it doesn't allow, because of the ligaments, to go in that direction. And that's a natural way the spleen starts coming up into the right iliac fossa. That's the reason we'll do that. But yes, smaller splenomegalis, you also have an insinuating method, which you can go behind the patient and just tell them to do that. Or you can make a fold of the skin at the left costal margin and just try to make that bridge so that you can go into that when you're having a mild splenomegaly to palpate upon. And your rest of the points about the categories of the abdomen, I would absolutely agree, because it's always good to have viewpoints from all the examiners. You can have a flat abdomen, a scaphoid, and maybe a distended and a protruent abdomen. I think that is a way, because this is one thing where the examiners are always, one will agree, one may not agree, and the student is always confused. So the one who is agreeing, they will always look at him, and that's the one of the trick which you should know. The one who is with you, you should look at him all the time, but don't miss on the others, because they should not feel offended. Dr. Kakkar, sir, any comments from your side, sir?
You did an excellent job. I would just like to add a word or two. I hope you wouldn't mind.
Not at all.
No examination of abdomen, as you rightly said, is complete without examination of spine. In addition to spine is supraclavicular fossa.
Okay.
External genitalia. And in today's era, take a patient's permission and look for internal examination, that is per rectal or per vaginal examination. And last but not the least, examination of posterior part of abdomen, especially for the renal angles, in case the kidneys are enlarged, that should be looked into, because that is also a part of abdominal examination.
Absolutely, absolutely well said. So examination from the front, examination from the back, that will give you a comprehensive 360-degree about what's happening. Absolutely, point well taken. And lymph nodes, especially the left supraclavicular lymph nodes, because we know sometimes a small malignancy in the testicular area can have a metastasis in that area. So I think that covers up the entire spectrum. Dr. Geeta, any comments from your side?
So just thinking, while you were doing, you divided the abdomen into 9 quadrants. So how, possibly the students also need to understand what would be the differential diagnosis. If you were to pick up a swelling, it does not necessarily have to be a hepatomegaly. If it is a umbilical swelling, it could be a mesenteric cyst. So, and mesenteric cysts can be very tricky. If it becomes very big, it can actually go into the pelvis and you may actually mistake it for an adnexal mass. So I think those differential diagnoses also need to be brought up very, very carefully. And for the supraclavicular node, yes, of course, your pancreatic malignancies, gastric malignancies, all of those can, give rise to a supraclavicular node, and that can change the stage completely. And like Dr. Kakkar said, the internal examination, I used to, actually, I should not be using the word delight, but, it's always a delight when you pick up things which otherwise would come up only on imaging. So if you were to do a per vaginal examination or a per rectal examination, you were to find a Blummer shelf. It's an enlarged gallbladder that you're feeling, and you can label her or him as a stage 4, just basis your examination, and then corroborate it with your imaging findings. So I think wonderful job, and Jignesh and Vivek, you have covered it beautifully. I think it's a treat for the students to watch things being done systematically. I think it is very, very important. You have to organize your thoughts in your mind in a very systematic fashion to be able to reproduce it every single time you lay your hands on any abdomen, or for that matter, any organ of the body. And I think you've done a great job of putting it in a supremely systematic fashion for the students to assimilate and thank you.
Yeah, thank you. So in a nutshell, what sir was trying to say is, given the Bayesian love.
Nutshell, I have a question. I do not know the answer. I would request any one of you or every one of you, you can laugh at me, who divided the abdomen into 9 quadrants? Does anybody know? I do not know. And it's surprising. We do it day in and day out, and we forget the person who did it. I do not know who did it.
Maybe so that's homework for me. I think probably by tomorrow morning, let me try. But yes, definitely, I think it has evolved over in the textbooks for many years. But who has done it specifically, I really don't know. But maybe this is something in exams the students can be asked to get a distinction.
No,
So
no,
remember,
it's not a question. What students may be asked:
yes.
Is it an anatomist? Is it a physician?
I think probably, sir, if I remember correctly, the whole thing has come from the anatomy concept, and that's where the transpyloric plane always used to be a challenge, because students used to say that at the level of 9 costal cartilage or at the level of pylorus, and then your quadrant suddenly becomes very, very small. And then in the textbooks, which evolved over a period of time, they said that the subcostal line should be there. So I think it started in anatomy, probably clinical anatomy, but definitely it's something which I'll try to look into, and I'll try to see whether I can get a valuable answer for that. But just a quick response to the first thing about the internal examination, Bailey law clearly tells us that if you don't put your finger into it, you'll put your foot into it. So we all know about that golden line, and it's like every student knows about it absolutely completely. So students, now it's your turn. Any questions from your side? Any comments?
Before we take up any queries, we also have one of the most eminent and popular pediatric surgeon, Dr. Satish Agarwal sir, among us.
Okay.
And
sorry, I didn't
I would
know
just
that.
like to take this opportunity to extend this topic to him. So if he can add anything else when it comes to abdominal examination in a pediatric patient, if there are any more points that that need more attention or that need to be specifically done in a child. So your thoughts.
Right. Okay. Am I audible, Mrinal?
Yes,
and
sir.
Everybody?
You are, sir.
Right.
Yes, sir.
So thank you very much. First of all, my apologies. I joined a bit late. As usual, I sometimes reach home late, but that's besides the point. Whatever I listened to was a treat, of course, and it was a relearning for me about several aspects. As far as pediatric angle of examination of the abdomen is concerned, I will be taking a separate session on acute abdomen in children, and I will cover most of that in that session. However, because we've had such a lively discussion on the need and the appropriateness of rectal examination and internal examination, I would like to highlight certain points if I am permitted. So first of all, rectal examination is not a part of kind of a routine examination in childhood examination of the abdomen. That's number one. So we do not unnecessarily bother a child, because it is not only distressing to the child, but it disturbs the family and the child starts crying. So use your discretion. Where it is necessary, you must insist. And I'll give you two classical examples where a simple rectal examination was instrumental in suspecting a diagnosis. And this has happened personally several times. One example is, if you have a child with constipation, always put a finger in the rectum. And I have had surprises in the shape of a presacral mass causing obstructive symptoms to the rectum. And the child had had a rectal biopsy done to exclude Hirschsprung's disease, because what comes to your mind is common things. And I am not exaggerating. I'll find that X-ray of contrast enema somewhere in my collection, a large presacral mass presenting as constipation. Another example, a child presenting to casualty with recurrent bouts of retention of urine for unknown reason. A small child, infant. You have worked up for stones, you've done umpteen numbers of ultrasounds, nothing matters. He comes to casualty in the night, gets himself catheterized once, goes home. Until one day, somebody puts a finger in his rectum to pick up a prostatic rhabdomyosarcoma. So such things can be missed. So if you have pelvic symptoms, rectal symptoms, bladder symptoms, please do put your finger in the rectum with permission. And do this with your little finger, not with your index finger. Sphincters are often very tight. Allow some time for the child to relax. Make friends with the child before you touch his abdomen. As far as examination of acute abdomen is concerned, most common example when you are suspecting appendicitis. Now, the children who have suspected appendicitis will reach a pediatric surgeon after having gone through some pediatric opinions, some ultrasounds, maybe a CT scan. Please do not look at the reports of ultrasound or CT scans. Insist on getting the examination of the child yourself. And when the child comes to you, do not expose his tummy just like that. If the child is a small child who cannot communicate with you, I prefer to examine the child while he's still comfortably resting in the mother's lap. So I'll change my position because my primary aim to exclude or to suspect appendicitis is if I can elicit some degree of peritoneal irritation in this child. It may not be in the right iliac fossa, it may be right hypochondrium, because we know that in children many a time the cecum is wandering. It may be in the right iliac fossa, and they're not very far apart as in adults. So if I put my hand and just observe very carefully what is happening to the child's face. Is he getting up from sleep? Is he wincing? Very gentle pressure on the abdomen, not on the exposed abdomen, but through the clothes while the child is still in the mother's lap. If you ask the mother to lay the child on the couch, you have lost the opportunity because the child will wake up, he will start crying, and then you are lost. So that's about, very briefly, the difference of examination of a child and adult. One question I would like to ask to every panelist here is how much importance do we give today to the finer points in the examination, say for example, colonic band of resonance. In last several years, maybe 25 years, I've never been able to elicit this sign. In fact, in children, I most often tell, at least these days, ever since corona epidemic has happened, that colons are not filled with gas, they are filled with solid fecal matter these days. They come with chronic fecal retention and not gas. So how important is this band of colonic resonance? I really wonder. Second, I've seen several clinics where if you suspect order an ultrasound, you don't go to an ultrasonologist. The clinic itself has, the clinician has a handheld ultrasound machine. And I know urologists who carry bladder scanners to see how much urine is there in the bladder if you want to comment on post-void residue. So we are living in an era where everything is advancing. So is ultrasound becoming a part of clinical examination? That is a question. And second, do we bully students on these finer points of examination? Sometimes I just wonder, I ask myself, am I doing the same test in the OPD every day? The things that we are asking the students? So if somebody could throw light on that. Thank you.
So actually, you have just echoed my thoughts. I had that question in my mind and I had Professor Kakkar to respond to that. I wanted to pose that question to sir because I think he has the most experience among all of us, and we used to be really taken apart on clinical examination.
Bullied badly. I've seen people failing on these small
points. I would request Dr. Kakkar sir to respond to that. How relevant is the old techniques and relevance of proper clinical examination in today's era where ultrasound is so readily accessible and we have all kind of imaging modalities at our disposal. So, sir, your thoughts, please, sir.
And sir, before Dr. Kakkar takes over, one more thing which Dr. Kakkar highlighted, and I'll echo my thoughts on it, and that's the examination of the renal angle and the spine. Now, in pediatric age group, we deal with several renal masses and renal pathologies, hyodonephrosis, Wilms tumor, other tumors of the kidney, and several things. So we feel that looking at the renal angle is very, very helpful. You have an opportunity to compare the two renal angles. If you just bare the back and have a look at there. Spine, Many times you'll find scoliotic spine in a child. Say, for example, he has a empyema, or he has one inflammatory pathology, chronic inflammatory pathology on one side of the abdomen, or a big lump in the abdomen. Spine will be scoliotic. Many times the child will come with bladder bowel symptoms, retention, constipation, and copresis. You look at the back and there is a big mass in the center of the back. Occult spinal dystrophism has normal skin, but slight bulge on the back, and there is the diagnosis. It's an occult spinal dystrophism. It's a neurogenic bowel bladder and nothing else. So spine and renal angles is a must. Everyone should comment that the spine is normal. Similarly, genitalia. A pediatric examination is incomplete if one doesn't comment on hernial sites. Many a time, small points. Many children will have an operation for a hernia. And if on the examination, if you mention to the examiner, sir, there is a scar mark in the left inguinal area, probably a previous surgery for hernia or something. And that gives so much of credit to the student that yes, he is thorough in his examination. So over to Dr. Kakkar, sir.
So, I agree and I disagree. I agree from students' point of view that when you say the lump is in a right hypochondria, you know the capacity of right hypochondrium according to the classical division. How can you describe a lump 9 centimeter or 10 centimeter by 10 centimeter limited to right hypochondria? That is the reason. Nobody's, in fact, today we say, forget 9 quadrants, divide it into 4 quadrants and tell us, is it in the upper right? Is it in the upper left? Is it in the lower right? Or is it in the lower left? I will name one of the very senior surgeons of the city. He couldn't make it in his first attempt in MS examination because he said the lump is in umbilical region and the lump was triple the size of umbilical quadrant. And examiner kept asking him, are you sure it is in the umbilical region? He said, yes, sir, it is. He made him ultimately measure it with the tape and he said, now tell me, man, is it in the umbilical region? Now you tell me, is that justified? Agreed, examiners can be bully-minded. I'm willing to admit this happens. And if one of the things which Britishers say or used to say was examiners like hunters, which today things have changed. Don't think examiners go with an idea of pulling you down, but you sometimes ask for it. They have not come with a standard set of questions to ask you. The questions will be from what you utter, what you answer. And the dictum is, if you lead an examiner, you are through. If the examiner leads you, well, God only knows where you will end up. I hope I've summed up the queries that you raised.
So, but what about what is the relevance of clinical examination in the era of ultrasound and newer modalities of imaging that are readily available? How strong one should?
Yeah. Shall I be very clear?
Yeah, of course, sir.
I hope the ladies and the gentlemen would excuse me. You got a breast patient. Would you straight away take a patient for mammography or ultrasound? If a patient has got a lesion in the rectum or has got an hydrocele, would you straight away go get an ultrasound done or would you like to examine a patient? Number one. Number two, if you do not touch a patient, if you do not communicate with the patient, how will you develop a rapport? How will you win over the confidence of that person? How will you show your empathy to him? And not only today and not only earlier, even any day, 50%, if I may be excused, of treatment is a communication, a touching, a listening. Talk with the patient, don't talk to the patient. That's a basic premise. Involve a patient in his treatment protocol, whichever way he can benefit. We have no right to dictate, no, I'm going to do this for you, and you have to accept it. No, that's not true. What is his circumstances? What is his financial status? Who is going to look after him at home once he is discharged? We have to take all these things into consideration before you plan a therapy. So mere investigation, no touching, I'm sorry, I don't agree. I'm sorry. I would never be comfortable if I were a patient or if I were a physician or a doctor treating a patient.
Sir, I'm sure Mrinal did not mean that. What he meant probably was these extreme details of examination.
Yeah, agree.
Yeah,
Agree.
thorough examination.
Thorough examination, like, oh, you haven't commented upon the band of colonic resonance. Oh, you haven't commented upon velocity.
No, those are there.
And by the way, Dr. Gandhi pointed to this out, and I'm very glad that he pointed it out and stressed upon it, because it's a common, very, very common mistake. I have done several examinations of candidates, and I have yet to come across a person who has described velotability and bimanual palpability correctly. As he very correctly said, a bimanual lump is futile to mention velotability.
Absolutely right.
When you shift the lump and it touches your anterior hand, only then it is velotable. So small renal masses will be velotable, large renal masses will not be velotable. So actually, see, Dr. Kakkad has pointed out a very, very important aspect in patient-doctor relationship, which is direct communication and the touch, feel of your hand. I can tell you, it is $100 million question today. I see it happening every day. In private sector, patients have gone to several doctors, several hospitals before they are coming to you for some opinions. And I am not exaggerating. Many parents tell me, sir, आपने हमारी file नहीं देखी. We have come with CT scans and MRIs and ultrasounds, and you are asking for the child. बच्चे को तो हम लाए नहीं हैं. And then I insist that I will be happy to give you my opinion only after seeing the child. I will not see these investigations, please. And then they get the child. And then they comment, after having gone through the clinical process of examination, after I have talked to the child, after I have praised his hairstyle. Oh, you look beautiful. Where did you get this hairstyle? Sir, mama made it. So the child opens up, and then I put my hand. I may not be able to pick up many findings. I may still be inferring several things from the investigations, but the mere fact that I have touched the child puts so much of confidence in parents' mind. And very often they tell me, सर हम बच्चे को इसलिए नहीं लाए थे क्योंकि पहले 10 डॉक्टरों ने देखा, किसी ने बच्चे को देखा ही नहीं. हम बच्चे को लेके गए थे, उन्होंने इन्वेस्टिगेशन देखी, इसलिए हम अब भी नहीं लाए. So that's the kind of attitude that we doctors are falling into, a trap of investigative modalities of getting at a diagnosis, forgetting that the first thing you have to establish is relationship with the child, with the family. When a patient comes to me in the post-op follow-up and is doing good, I always make it a point to praise the mother. Well, mom, you have taken very good care of the child. It's because of you that your child is good. And they feel so happy. So communication, touch is very essential in clinical examination and establishing a doctor-patient relationship. Thank you, sir, for bringing this out. Thank you.
Yeah, that was the whole point of putting that up, because we wanted to put that point across to the residents that no matter what situation, you can't just omit a clinical examination, even how strong technology can be. But clinical examination is here to stay, and it will be forever, because you can pick many small and many big things just by doing an examination, which you may even miss on imaging modalities. So I think the students are really lucky here, because what you are listening to here is more than 100 years of teaching experience, more than 100 years of examination all these faculties, they are very senior. They have so what you are hearing from them is like the trade secrets of passing an examination, of what the examiners actually want to hear from you. So I would ask now Dr. Geeta to conclude the session and to just wind up and to summarize the whole evening for us.
Thank you.
Rinal, somewhere along the line,
Yes.
Yes, sir.
Rinal,
Yes, sir.
somewhere
Yes, sir.
along the line, I'm also sitting. And I just like to make a point. You've totally forgotten the situation. You see, the point remains, I think you can border on the ridiculous if you go to either of the extremes. That means if you're too dogmatic, then also you're being ridiculous. And if you're, on the other hand, if you depend totally upon the investigation, that's also ridiculous. But then I thought this is probably not the discussion we should go to the postgraduates. They should get the classical methods which Dr. Gandhi is so beautifully outlined, actually. But the fact still remains, I think in today's times, many of the assumptions that were made with reference to clinical examination must be reviewed. And we must bring the whole thing back into focus in today's context. It's going to happen, and it will probably enter the textbooks someday so that the examinees get the benefit. And probably, and at the end of it all, the examinee being a candidate in a nervous state of mind should get some benefit.
I'm sure, sir, all the residents must be very pleased to hear that, those
Yes.
last words from you for the end of the session. So that would be very heartening to them. I'm sure of that. Thank you, sir. Thank you, sir, for your input. So, Dr. Geeta, ma'am, please.
Thank you very much. And I also believe that examination, communication, just holding the patient's hand, and all these things are never going to go out of fashion. Because you must realize that you will go out of fashion if you were to omit these basic fundamental needs of a human being. And I also think it is a good habit to look at your investigations yourself. You don't have to be a radiologist, but putting up, I am always in this habit of putting up the mammogram film first. I don't read the report. It's just a habit that I've cultivated just to, see what I see. And there have been times when I picked up things which the radiologist missed, and vice versa also. But it's something that I think is a good habit to develop. And all these bits about, inspection, palpation, percussion has got more to do with due diligence more than anything else. It like I said, you have to be systematic in your behavior. Only then, as you grow older, you can condense it into a smaller piece and then get the same kind of information. I'm not saying that if you were to do those 4 steps only, then you get complete information. You can condense it into a smaller version which works for you. But you have to get to that point. And before that you get to that point, you have to follow due diligence. But like Dr. Kaza said, very, very important to review, because we have to spend our time and energy on things that matter and give us the maximum information, rather than trying to dwell upon possibly a replication of the information that we possibly get at step 4 instead of doing step 2 and 3. So that's what I think. So it's been a great experience today as well, and I'm sure there is more to look forward to. And I hope you have learned a lot today. And the discussion that happens on the side, I'm telling you, that's also very, very, very important, because that is what is going to shape you as a surgeon, as a human being, and also hold you in good stead as you come across patients. And especially in private practice, there is always this thing that, how do you retain patients? I think there is fundamentally nothing different at all. You just have to be your normal, natural, spontaneous self. Be honest to what you do, and that honesty will shine through. Thank you very much, and have a very good night.
Thank you. Thank you.
Bye.
Thank you, everybody.
So we
Just one
thank.
second.
Thank you.
So
Dr. Jignesh, you have a homework.
Yes, sir.
I'll
Nine
be
quadrants.
grateful if you can get me
Maybe
the
nine
number.
quadrants.
The answer will be on the group tomorrow at the morning when you're going to have a cup of tea. Yeah,
Sure.
sure.
So much. Thank you so much.
Okay.
Thank you,
So
sir. Good
I-
night.
Bye bye.
So
Great.
on
Bye-bye.
behalf of
Good night.
Conceptual
Good night.
Surgery, we thank all the senior faculty, Dr. Kaza sir, Dr. Kakkar sir, Dr. Satish Agarwal sir, Dr. Geeta ma'am, Dr. Jignesh sir, for taking their time out. It's been a long day, but since everyone is here with all their inputs, with all their zeal and participation, thank you everyone.
Thank you, everyone.
Thank
Bye-bye.
you.
Okay, good night. Good night.
Bye.
Bye.